Welcome, everyone, to this talk. It's actually a real pleasure. It's the first hybrid Eawag seminar talk since more than a year. And I'm particularly pleased to welcome Katrina Charles, professor from the School of Geography and the Environment from the Oxford University. And Katrina Charles will be talking about integrating water quality monitoring in service delivery models to achieve universal water safety. And this is a topic that is very near to our heart as well. So we are looking forward to her insights and learn from their experiences. As Dr. Charles is using interdisciplinary approaches to analyze our understanding of environmental health risks and how to communicate those risks and affect change in society. She is leading projects on drinking water quality and climate resilience and aiming at supporting progress towards the Sustainable Development Goals. And she's doing that with the interdisciplinary research team that has expertise in water quality, health, and social science. And she's also working in very close collaboration with NGOs, international organizations such as UNICEF, and with local governments. And Dr. Charles is a trained environmental engineer from Australia. And during her PhD, she focused on pathogen faith in the environment. Also during her postdoc, she looked at quantitative microbiological risk assessment. And she also looked at the impact of climate on water and sanitation, and also looked at enabling environments for sanitation in small urban settlements. And since 7 years, she is working at Oxford University. And in addition to all the projects she's involved with, she is one of the co-directors of the REACH program that aims at improving water security for the poor in Southeast Asia and in Sub-Saharan Africa. So welcome, and I'm very much looking forward to your insights.
Thanks very much, Regular. It's really exciting for us to be here at this first hybrid session and to be able to come in person and to meet with everyone here. So very much thanks for having me and having us, because Saskia Novitsky is here with me, and I will introduce her a bit more as I go along. So I became very interested in this topic of who uses drinking water quality data across my career, and I wanted to spend time talking about that today. So I was fortunate enough to do my PhD in Sydney a few years after the Sydney cryptosporidium incident. So that was an incident where there was a boil water advisory because cryptosporidium had been detected. No one got sick, but it became a time when I was working closely with the government where there was a real interest in the data and interest in the research. There were people within that organisation who'd been brought in just to deal with these water quality challenges. And so there was a really receptive audience for the data. And it meant we had a lot of scope to do interesting research, but people were really interested in learning about it and passionate about taking it on and changing the way things were managed within that organisation. And we were lucky there that there was lots of data, and we had plenty of data to work with. And we had this willingness to learn, and we were able to, and they were implementing a risk-based approach. So they were looking, okay, let's understand our system, let's understand the risks, and also let's challenge our existing knowledge. So there was lots of different research that came out at that time that really shifted our ways of thinking about catchment management and drinking water safety. But as I've moved into development work and focusing on development, then there's been a lot of similar research going on, but there's not quite that same connection to the data users. There's not that appetite to take that research and implement it and change the way things are done. And so that's why I've come back to this question of who's using that water quality data, because we're producing a lot of it, as I'll go through, but what's happening to that, and how can we use that knowledge to better integrate water quality monitoring into service delivery models? So I'm going to, across the talk, what I'm going to speak about first is to landscape it a bit in terms of the drinking water safety crisis that we're facing and the need to monitor water quality. So not making the assumption we have to monitor it, because in a lot of situations, most people who are trained in water quality sciences can look at a system and see, okay, I know how to improve this without needing data. But it's more how do we get to safety? What is it? What is the monitoring we need to do to get to safety? And then I'll look at the evidence for where is drinking water quality monitored and who's doing that work. What does the data tell us about drinking water safety? And then who is using that water quality data to make change. And I'll conclude by sharing some of the ways that we're working to advance new institutional models, new ways of working within institutions and organisations to embed water safety into their work. So the latest report from WHO and UNICEF's joint monitoring programme highlights that there are 2 billion people who lack access to safely managed drinking water services. And this map gives you an idea about where those people are located. The grey areas, though, represent the 55% of the population where we don't have data. So there's not enough data to tell us about those areas. We know that safely managed drinking water is more than just water quality. So it's also about whether it's accessible on premises and whether it is reliable and so people have access when they need it. But it's water quality which is the main problem. And so there was an analysis published a few months ago from Rob Bain and colleagues where they highlighted that E. coli contamination was the primary reason that safely managed drinking water criteria were not being met. That was the case for 15 out of 27 countries where they had data. This data is based on the UNICEF's multiple indicator cluster surveys. These nationally representative data sets that are used to inform policy. And so what these graphs highlight here, they're showing the diversity of the differences between countries, so how many are free from contamination, and particularly that gap between urban and rural, that we have a lot of those people who don't have access to safely managed drinking water are based in rural areas. And from the map previously and from some analysis, further analysis in the report, we know a lot of those people are in Sub-Saharan Africa and Central and Southern Asia. And in fact, what they've suggested from their analysis is that in fragile contexts, which includes a lot of the countries I work in, so Bangladesh, Ethiopia and Kenya are all included in that, that progress in those countries needs to accelerate by 23 times to meet the targets that have been set in the Sustainable Development Goals. So there's a real need to do things differently. We need to change how we're working if we're going to meet that target. And the reason we need monitoring to do that is to really challenge some of the assumptions of safety that are out there, of water safety. So this is a quote from a book about groundwater and health, but it very much reflects, I think, the attitudes that have pervaded the industry, that groundwaters often require little or no treatment to be sustainable for drinking, whereas surface waters generally need to be treated often extensively. So there's this assumption that if we can just do the infrastructure right, we don't need to do anything to manage that water quality. And that's led to a situation where we've got a lot of contamination. So the graphs here are from the latest Bain paper as well. And this one's for boreholes and tube wells. And so overall from that data set, they're saying that 10 out of 21 countries have over half of the boreholes they've tested having contamination. If we look, so boreholes are a better groundwater technology. If we look at protected wells and springs, it's an even worse picture. So in their 19 out of 23 countries had over 50% of the protected wells and springs they sampled having fecal contamination. So there's this huge issue where you've got a lot of people who we thought originally had good access to drinking water, they're actually drinking contaminated water. Across the MDGs, this approach of assuming groundwater is safe meant that we used improved sources. So there was this idea of infrastructure is the priority. And now there's a shift to recognise that we need to manage water safety more. These high numbers, of course, are not just numbers of water points that are contaminated, but it's also implications for health of the people who are using them. So these are people who are using untreated, unmanaged water supplies with implications for high rates of diarrhoea and diarrheal diseases, but also it's related to things like environmental enteric dysfunction and stunting. So you have these chronic developmental issues that means people aren't getting a good chance at life, that they are challenged right from the start. And then, of course, that's just the microbiological side. I'm sure there'll be plenty of people here who work with chemistry in waters as well, will recognise that water safety is so much more than just the pathogen risk. This idea of groundwaters not needing treatment may have come out of that risk, that the idea that this water is filtered and we don't have to worry about pathogens then. But there's also a lot of risk we know from chemicals in drinking water or in groundwater. So we've got then the data to show this global picture of showing that there's this huge need for change on water safety, a need to do something different and to challenge people's assumptions about what is safe as we make that progress. So what I'm going to, as I go through the presentation, I'm going to draw on some research we've been doing in a number of countries, as well as on some broader research that's been done by colleagues in Acquire and internationally, to look at who's using drinking water quality data. And so that includes some of the REACH research. We've had collaborations with World Health Organization, UNICEF, Rural Water Supply Network, and Uptime. We've been working in Bangladesh on household, school and hospital water quality, looking at and using nationally representative data from the Multiple Indicator Cluster Survey. In Kenya, Saskia has been leading a program where we've been looking at rural water quality, working alongside Fundifix, who are involved in, they've been trying to improve the maintenance of and the reliability of water services. And so now we're working with them to try to improve water quality. And so that's involved water quality in households, schools, and healthcare facilities. And we've also had a collaboration with Acquire to try to drill down onto some of the previous data they've collected on monitoring for safe water. And finally, there's a more recent program on a global survey of service providers we've done. So that work is being launched later this month. So it's hot off the press for this. So firstly, next I wanted to move on to where is water quality monitored and by who? We monitor drinking water for all sorts of different reasons. So we monitor it for research purposes, of course, for these national representative surveys with mix. But the kind of data that I'm going to talk about more is the data that's collected by suppliers, by service providers, and for surveillance purposes. And so suppliers, we're talking mostly about piped water systems where people are involved in that bulk transport of water to people. Service providers typically includes more rural providers where they may be providing a service which is maintenance, it may be safety, but often the infrastructure is already there. So water, this is an analysis done by Acquire, which was looking at water quality sampling behaviours across 72 institutions in 10 countries in Sub-Saharan Africa. So one of the things to point out that there was a similar number of suppliers and surveillance agencies included. So there was 27 suppliers and 25 surveillance agencies, but the most samples by far are from the suppliers. And these particularly were urban piped water companies. So most of the sampling comes from them and it's focused across those urban water distribution systems. Surveillance agencies are doing much less sampling, but it's much more likely to be in those rural areas that I was highlighting where we have the most concerns about water safety. Overall, across these different suppliers and surveillance agencies, 85% reported doing some microbial water testing in the past year. 75% reported testing regularly. So lots of them are testing regularly and testing the water. Not surprisingly, suppliers had higher budgets, more staff, so they could do more tests. And there was a difference in how they sampled. So suppliers were sampling systematically across their systems, although we don't know exactly whereas surveillance sampling was reactive. So they were going out only if someone had a concern. So if there was an outbreak, they would go out and test the water. So they had, when you see the results, they are quite biased by that fact. One of the things they've looked at across the analysis is how do this rate of sampling compare to the World Health Organization's guidelines for sampling. So WHO sets guidelines based on the population for how frequently they should be sampled. And here, the points below the line are the ones which are not sampling frequently enough. So they're not sampling as much as would be expected by WHO. This part of the data set included a number of agencies who were involved in their monitoring for safe water program, which meant they were being funded, they were being supported for monitoring. And they found that those ones would jump from, say, a sampling rate of 67% of the guidelines to 167%. So they had a big increase during that program. So some of the ones here, which are above that line, are likely to be inflated. I think overall they had about 37% who were testing adequately across the previous study. Here it's, I think, a bit higher. But so you've got a lot of sampling going on, but not necessarily at a level that's sufficient. What we've been working on most recently is this survey with Uptime. So whereas Acquire had worked with the surveillance agencies and the urban piped water suppliers, we've been working with the service providers who are kind of supplying more rural areas. They're supplying smaller systems. They're often managing hand pumps as well as piped water systems. And so in this survey, we've reached 257 non-government service providers. We had a number of governments who also responded. And they were over a broader area than the Acquire study. So this is including in Sub-Saharan Africa, South America, Asia, a good spread of suppliers. And again, people report that they are engaging in regular testing, regular water point monitoring. So this one, in this case, it's 67%. So across all of these, the studies are showing that water quality is being tested regularly, but it may not be being tested at a level which is often enough in line with WHO standards, but we do have, this does indicate we have capacity, we have the ability to do these tests, and to a certain extent they are being done. So what does that data then tell us about drinking water safety? So this is a lovely picture from a sculpture of E. coli from an art exhibition at Natural History Museum in Oxford. And I think it's worth mentioning here again that I'm going to focus on E. coli. I do recognise that water quality is much more than E. coli, but it's the main thing we measure. It's the main measure that is used internationally to assess drinking water safety. So what I've been talking about so far is about the sampling, the measuring of water quality parameters. What I'm going to move on to further here through this framework that Saskia and I worked on is to look at quality, how we interpret those results. How do we interpret those results to give us an idea about health outcomes and risk from drinking that water? And then onto safety and how we track the safety of drinking water services. So there's 2 points in relation to quality that I'm going to make. First, about how we sample, and the second is more about what the E. coli is that we're sampling. What do we know about those E. coli more broadly? So I should point out that there's many things I could say negatively about E. coli as well. We was asked that question earlier today, and I have many things that I don't like about the use of E. coli. But I wanted to highlight two things in particular. Firstly, it's how we're sampling. A lot of the data that we're sampling, we need to understand how it's being sampled, because that also affects the actions that we might take. So I'll come back to that picture in a moment, but there's three different ways we sample water. The first two are how mix samples it. So at the far side, you've got the point of use water. So that's water as consumed. And we sample that by asking someone for a cup of water as they would give to a child. And so that tells us about that water as they are consuming it. The second way that we sample is source water before decontamination. So that's when, say, from a hand pump, that you would flush it and then take a sample. So you flush the water and then you take a sample. The problem with that water, that type of sampling, is that it's giving you two pieces of information that are mixed in, so you can't tell them apart, that you're getting both water quality that's from, say, the groundwater or water that's from that pipe system, but you're also getting contamination from hygiene. So, for example, if I step back for a moment, point of use. In Bangladesh, from their mix survey, from households who had safe water at the point of collection, so they were taking it from a tap or something and it was safe, by the time they'd put it in a cup and given it to you for that sample, 2/3 were contaminated. So there was 2/3 of that contamination was coming just from people's hygiene practices in their household, just from that cup. So it's a huge contribution to it. So the third way we sample, which is common in Bangladesh, so ICDRB in Bangladesh do this, is they decontaminate that water, that sampling point. So they're using a flame often. So in this case, they're holding up, they've got alcohol on that cotton wool ball, and they've lit that, and so they're using a flame to kill off any of the bacteria that are on that sampling point. If it's a plastic tap, they'll use a wipe instead and use an alcohol wipe. But when you do that, you're getting a very different picture. You're able to understand what that source water quality is. And those different types of sampling are important to know where the action is, what kind of action you should be taking. So if that water contamination is coming from the ground, you need to change something about the source, whether it's treatment or a new source. If it's coming from hygiene issues, then it's a more localized response. And this is something where many studies don't report that methodology clearly. So it's actually very hard to look at studies and compare them and work out what they're telling you. And the implications for this are quite considerable in terms of how we interpret data. So in Bangladesh, we looked at this from a number of studies that ICDRB have done across Bangladesh. And so in these bar graphs, the blue ones are the ones, the bigger ones are the ones which have been taken before decontamination of that water point, and the green ones are after decontamination. You can see there's a huge drop just from decontaminating that sampling point, just from decontaminating that tap. And that's uniform across every study they've ever done. In terms of what that means for Bangladesh, we've looked at that in terms of the mixed data. So in the mixed data as reported, 63% of people were collecting water from sources that were contaminated. If they were decontaminated, our estimate is that it would be almost 90% who were drinking safe water. So there's a huge disparity there between those numbers, and it's got big implications for how you manage that water, what your response should be. There's very little in the literature about something as simple as cleaning a tap or a hand pump. And without that, it's very difficult to interpret a lot of the data. So the second point I was going to make about E. coli are reflecting on, are they an appropriate indicator of fecal contamination? So there are a list of criteria that we use for choosing fecal indicator bacteria. One of them is that fecal indicator bacteria should not multiply in the environment. What we see is that there's a large body of evidence that they do multiply in the environment and that it is problematic. So the drinking guidelines for drinking water quality even specify when they're talking about E. coli that water temperatures and nutrient conditions present in drinking water distribution systems are highly unlikely to support the growth of these organisms. When we're talking about rural water systems, we're talking often not about pipe systems. So then what are the implications in those systems? But more than that, a lot of this research is, there were assumptions about water being from E. coli is not growing in temperate climates, but I think there's evidence now that shows that that's not true. And we know that there's a lot of variability in temperatures and nutrient conditions that are leading to E. coli growth. So Saskia led a study which was using whole genome sequencing from 14 water supplies in rural Kenya, which were some were high levels of contamination, some had low levels of contamination. And what she found through this was that naturalized E. coli populations may be the source of contamination at collection points, and particularly with lower E. coli concentrations. So ones that had that lower level, that 10 to 50 level of contamination per 100 mil, those ones are more likely to be types of E. coli that were more resistant in the environment, whereas the types of E. coli you see, which are less robust, they were more likely to be in point of use or high contamination sources. So it makes us question then, okay, is E. coli the best thing to use in these settings? We've looked, there's a lot of exciting work at new indicators about how we can avoid E. coli, but it's not enough just to make it faster. We're still going to have those problems with E. coli if we're just making it faster with rapid testing, rapid types of testing. So we've also looked at some of these novel metrics. So this one was tryptophan-like fluorescence, where we saw reasonably good agreement with E. coli, particularly when you consider that potentially the ones with the intermediate risk category may also not represent recent fecal contamination. But one of the things that's clear with these still is that they give us good evidence, but you need to have enough data that you've got a trend. And it needs to be contextual. So again, it's not a replacement for this one-off E. coli sampling that people are looking for either. It helps us understand water systems, but it needs a level of management to understand what that means for that water system. The second point I wanted to make was coming back to this tracking safety of services. So a water supply is not safe if it produces one glass of hazard-free water that happens to be when you test it, nor if it delivers pathogen-laden water briefly once a year. Often we're not testing enough to understand that risk, to understand if that is that once a year risk. And a lot of that data so far that I've been sharing isn't getting at this risk. So it was not frequent enough from some of the surveillance agencies and utilities, or it wasn't detailed enough. This is some example of work we've done in Bangladesh, where we looked at water quality monitoring across more than a year at different sites. One of the key things here in terms of variability and understanding and interpreting E. coli results is looking at that relationship to weather. So in November, in particular, the water quality at the point of collection was much better. There was about 70% that were safe. If you compare that to when the rains hit in the monsoon, suddenly you're down to around 40% of the water systems are safe. So there's this huge variability, there's very poor climate resilience among water systems. And we see this in all different countries. So we've done work in Nepal and Tanzania as well, which show similar patterns across all types of improved drinking water systems. We see that relationship where with rainfall, and particularly heavy rainfall, you have a deterioration in water quality. We've seen with that too, that with extreme events, you're getting more contamination. And that has big implications as climate change progresses and we're seeing more variability in our water systems. We're going to see more of this variability in water quality as well. And if that data doesn't address the seasonality, then it's underestimating the risks. So while the picture previously with Bangladesh looked very good, that actually if we could just clean a few hand pumps, we'd have much better water quality, it's not quite the full story. So if we look, comparing the latest round of sampling, which was 2019, with the previous one, which was 2012-13, there was a pretty similar level of contamination in water sources at the point of collection and a big deterioration at the point of use. But that's compared to all the other metrics which show us that things are improving. People have more access to improved water, they have more access to water on premises, they have better sanitation, they have better access to hygiene. Everything that we would associate with better water quality outcomes is improving, but water quality wasn't improving. And the reason for that is the weather. So the study that was done in 2012-13 was done mainly in December, January, and earlier in the year when temperatures are low. So the middle graph is temperatures are lower, and rainfall is much lower. Whereas the more recent study was undertaken in these later months into the start of a more rainy season. There's rain and temperatures are rising as well. And so comparing the results, which we did with regression as well to look at controlling for system type and where there was location of sampling and other factors, which supports this evidence, but that the proportion with no E. coli, so the green bars, you get a 10 to 20% jump in the proportion with safe water when you compare them in months where we have like-for-like data. So it's important to understand how we're sampling to really get an idea of that risk. And often the evidence we're collecting isn't giving us that data. So this is some of the evidence from schools, again, making this point that this is work that was done in Kenya, where across these systems, we've mapped out the positive and negative results for E. coli. And there are 2 systems where we didn't detect E. coli at some point in that sampling. But what it also highlights is coming back to these multiple risks, that it's not just about E. coli, that those systems, they may have had no E. coli, but they had other issues in terms of health parameters. So manganese in the first one, for example. You do not want a school which has high manganese, because manganese is associated with poor cognitive development. So that seems to be defeating the purpose if you have that at a school. So we have these multiple risks that we need to understand to really understand water safety. So who then takes this data and is making change? How can we make sure this data, firstly, who is taking this water quality data to make change? So if you think for the mixed survey, the mixed surveys are used to create change through influencing policy at national and international levels and financing. What it doesn't do is it doesn't come back and give information to that water point manager, to the person who's drinking that water. So there's not that feedback loop in that system. And that's fine, it's making change in a different way. Acquire, analyse the actions taken in response to the Monitoring for Safe Water program. So this, again, coming back to that data for formal water suppliers and public health agencies in Sub-Saharan Africa. But first, it's important to look at what they were looking at. So for suppliers, they were mostly dealing with piped water systems, or almost exclusively with piped water systems, whereas surveillance agencies who had this reactive sampling were more likely in smaller rural areas. And the difference in water quality is quite significant, that piped water and public taps, this was quite high performing water, so very low contamination, whereas the ones which are more likely to be monitored by the surveillance agencies had a lot more contamination. I want to point out first though, piped water is not always that good. These results may be a little bit biased by how they're sampled. If we look at piped water more generally across the 27 countries we have mixed data for, again, similarly to the previous ones, we see a lot of contamination. So in this case, 8 out of 27 countries had more than 50% of piped water samples contaminated. So there's a lot of contamination in water supplies generally, in piped water supplies still, that needs to be addressed. So if we look at the actions that they took in response to these water quality test results, the majority of actions were by surveillance agencies. So that shouldn't be too surprising because they were the ones who had the worst water quality and were more likely to sample if they were worried about something. For suppliers, they were taking actions that were operational. They could adjust chlorine, they could flush or disinfect pipelines, so they were taking actions that would seem reasonable. In rural areas, what the surveillance agencies were doing was more about education. They were educating about household treatment. So that's most of their actions were going to that household and saying, you have contamination in your water supply, you need to do something. And that's a really difficult thing for those households to act on. These are often, certainly some of the areas we work in, these are very, you've got high levels of poverty, you've got poor access to resources, poor supply chains, and it's difficult for the households to take action. I think it's also important to point out here that that surveillance is reactive. So what's happened is those communities have said, we're sick, come and measure, come and help us. They've gone and tested their water. So there's a bias in that. They've not necessarily known that the system could provide safe water. So they've just come out and said, okay, we've tested it, you've got E. coli, that's your cause, treat your water. With very little data. So there's a real positive bias in that of thinking that a detection of E. coli meant that the system was the problem. One of the issues with these data, so broadly we work with Acquire further on some of this work to expand it out and revisit some of these water suppliers in Kenya in particular. What we found was 3 years after this program, they weren't monitoring water anymore. So that incentive had gone and they'd stopped that behaviour. They did look back at what actions are taken in response to contamination broadly. And so this one again is the Sub-Saharan Africa group, the wider group. Here, there was a real tendency for suppliers to verify contamination. So if they got a positive test, the first thing was to go and take another test. And if the contamination had passed, it was fine. For suppliers, though, we come back to this idea of it's engaging consumers. This is the action that they're taking. In Kenya, we looked more at how you track what happens to that data in more detail. And so the data it's collected, it's paper-based, and often when they're communicating it to another agency, it's still paper-based if they're reporting it to someone else. The reporting then is a very slow process, so it's not a case of we have contamination, here's your result, off you go. But when we've talked to surveillance agencies in Kenya, it's more a case of, okay, I'll find someone to go out to that site, might take some time. They then have to take the sample by public transport to Nairobi. So that can take a day. Then there's the time for processing the sample, and they have to pick the result up in person. So again, paper-based and take it back. So that's 3 days of someone's time to do one piece of water quality monitoring for surveillance purposes. And that means that data is not available for quick action. And what we saw in Kenya more broadly is that no institution or national stakeholder was synthesizing data to understand water quality trends, to understand the geographic variability, to look at these risks and understand where they needed action. Some of the work Acquire have done have looked more then at what the implications of sampling frequency means for data users. And what they concluded from these models was that if you had, for example, the dots are the different agencies and how often they were sampling. So here we've got 5 samples per month. And then the months until they could detect a change in that water quality. And so with the frequency that they were sampling, you ended up with it being, for 35% of the agencies they were working with, it was more than 2 years before they would be able to detect a change in that water. And what made it harder was that often these water systems weren't providing consistent water. So it wasn't that these were safe water systems where you had a change would be very noticeable. But that scattered there is systems where the water quality hasn't been, haven't validated that those water systems can provide safe water to people. So that sampling frequency is not providing information to track longer term change. With the work we've been doing with the 100 Million Initiative, where we've been interviewing or doing a survey with service providers, again, I said we had 67% report undertaking regular monitoring, but only 31% report doing a suite of activities. So on that side in blue, you've got water point monitoring and the proportion undertaking that. At the bottom, the small section is sanitary inspection only. So they weren't testing the water, they were just doing sanitary inspection. And you can follow it along across this diagram to look at how many were doing multiple actions. And overall, you've got 31%, so about a third, who were actually doing that suite of water quality monitoring activities where they might be able to use water quality data to make change. And particularly service providers who were doing that monitoring, coming back to, again, to the importance of monitoring, service providers who were doing monitoring were more likely to actively manage water safety through treatment and interventions. So if they weren't doing it, then the chances of safe water at the end were pretty low. Where they have less resources, where they have where they're not getting subsidies, service providers were more likely to rely on things like sanitary inspections, which are great, and community water safety plans, which really focus on hygiene issues. But there was no evidence of follow-up actions. There was no evidence that they were treating, that they were responding to risks. So what I've put together then is, based on this evidence, is typologies of water safety. And I've split these out into larger, more pipe systems and smaller non-pipe systems, and characterize them in different ways. So for piped larger systems, we see there's monitoring by suppliers, systematic monitoring. We've got preventative actions, we've got treatment, we've got water safety plans, although some of those might be community water safety plans, which are more focused on hygiene rather than on understanding water quality. And there's a response. There's reporting to water managers, and this is something we also saw in the service providers. That was a positive action. If they were reporting to water managers, they were more likely to be treating the water. We also see operational changes. But we know that the systematic monitoring may not have the frequency that's needed. For smaller systems, it was monitoring more by surveillance agencies and somewhat by service providers. It's reactive monitoring, so that we have this timeliness issue of when the data is getting there. There's preventative actions, but these are much more focused at the household. And again, the response is focused on the users and the household. And so some of Saskia's work has focused on self-efficacy. And so self-efficacy is about someone's personal ability to take measures to control a threat. So is the person you're giving data to able to take that data and do something? And that's certainly from the Kenya context where we work, where it is a fragile environment, it is a fragile context. People are not able to do that. And what Saskia has been able to demonstrate with her work is the need to report data at the right level, to report it to a manager level, someone with responsibility within their job for delivering change. And that is what's needed. In other contexts, we know there's been some great studies that have looked at that household behaviour change and shown evidence can make changes. But within these fragile contexts, that's not what we're seeing. We're seeing to reach the hardest to reach, we need to do more communicating with managers. And what we found generally was that there was managers across all different levels, whether that's community water managers or professionalised managers. So let me go through this one at a time. Why don't water quality monitoring data lead to change? These are, firstly, this is assumption that groundwater is safe that I talked about at the beginning. And this means people aren't monitoring and they aren't treating. In Bangladesh, what we see there is that they're aware of arsenic, and so they have these arsenic safe programs, which is about drilling wells, deeper wells, to avoid the arsenic rather than treating it. And that the approaches that they've used to enforce that means that the people are less likely to drill wells in difficult hydrogeologies, so that those people don't get the wells. In Kenya, what we see is that development partners come in, and if the well in these water scarce areas, if the well is even slightly above the fluoride level that's recommended, they will cap that well, and that water's not available to anyone. So we've got this approach where people are just avoiding treatment, avoiding treatment in particular. I've highlighted how the data is not designed to inform change because of the frequency of monitoring, about how we're sampling, and about the limitations of E. coli. The politics is one that's really important. It's come across in a lot of the work that E. coli is something people are very happy to talk about, fecal contamination, because they blame the householder. It's the household's responsibility. And this comes back to the surveillance agencies, that they're putting it back on the household to treat this water. When it comes to geogenic concerns for fluoride and arsenic, the government suddenly gets sensitive. They consider that's their responsibility. And so they're less interested. They don't want you to report that data to anyone. And there are restrictions on what you can do with that data. It means there's less transparency and it's more difficult to make change. There are unclear responsibilities. So in Bangladesh, one of the particular areas we see this at is between agencies. So we work in hospitals and schools where you'll have another agency who's responsible for providing the infrastructure. So in Bangladesh, Department for Public Health Engineering, they provide infrastructure, but there's no maintenance of it. So it's expected that the hospital itself would provide the maintenance and the management of that water system. And what we see as a result is there's no treatment and the water systems are highly contaminated. And then I mentioned too, self-efficacy. We need to be getting data to who is going to use it. So I'm conscious, I think I'm probably running over time already, but I'm going to highlight just quickly some new models to advance drinking water safety that we're working on. Firstly, there's fit-for-purpose laboratories. So we're working with Sarah and the broader team. We've been working in Kenya for a number of years alongside Fundifix to implement these laboratories which are really targeted at getting data to service providers so that those managers who are managing those water systems have access to that data. And it's not taking days for a sample to go to Nairobi and to come back. So this is, we're using laboratory test kits. So this is using IDEX rather than using a field test kit to get higher levels of reliability. We have, and having dedicated personnel who are working full-time on water quality to get that data. And this is one where it enables you to give you an understanding of the water system performance as a basis for making decisions. Not necessarily sustainable at this scale, but this is where we're working with Sarah still. And now we're excited to be working with Regina and Lucas as well on treatment options for where we have come across problems in these water supplies of how we can implement chlorine. So that's about providing the data. Secondly, we're working with Uptime. So Uptime's a consortium of professionalized service providers who are trying to improve reliability of water points. So across Africa, they estimate that only a third of hand pumps are working at any one time. This is what Uptime is trying to address, trying to make sure those water points are more functional by looking and then create contracts with service providers where they get payments based on reliability, water volume produced, and local revenue, collection of local revenue to make these sustainable. And it's supporting the financial arrangements to take these to scale. For water safety, we're working with them to bring water safety into these arrangements. So it's not just about reliable access, but reliable access to safe water. So we're looking at tracking metrics for how many water points are they managing, where water safety is maintained. So that's water safety activities more broadly in terms of water safety plans, sanitary inspections, monitoring, treatment, a full suite of activities. And then also looking at water points with water safety improved, where they're improving their performance, and how they're making sure they communicate results so that they're communicating those results back to the government and to users. One of the issues that we've found is that in our work is that if you come into a water system that's already set up and you want to try to improve water safety, there are lots of barriers in place because you've already got these relationships formed between the communities, the users, and the service provider and the government. So if you come into that system and you say you have arsenic, it creates a problem. So what we want very much with these systems is that they're already communicating data, so they already have at least relationships. So if you bring in new evidence about this isn't working, there is a relationship already that you can build on. And then lastly, we're working in Bangladesh with Safepani. So that's a professionalized service delivery. So in Bangladesh, they met the Millennium Development Goals, but a lot of that was through private supply of water systems. And it was very much focused on infrastructure with some consideration of arsenic. What we're pushing them towards now with the SDGs is to have professionalized service providers who are again managing reliability, but also managing safety, that are looking at monitoring those water systems, acting on those results, and working with the government to make sure, particularly the government-owned water points, so the ones in schools, healthcare facilities and for communities, that these ones are providing safe water. And part of that very much is shifting from this previous mixed model to trying to collect data at scale in Bangladesh so that there doesn't need to be that nationally representative study done, but rather that there's data coming in all the time nationally, but also that that data is feeding back through right to the drinking water manager so that they can act on it and improve water locally. So thanks very much for your time. I think in conclusion that it's really critical that we shift the ways of thinking so that we can address these drinking water safety issues in rural areas rather than leaving them behind. And to do that, we need to think about that data and make sure that we're collecting data that we can use, collecting data that we understand and can act on. And we need to shift how we structure water service provision to really embed water safety at its core. So thanks very much for having us here. It's been really brilliant to come and visit. Thank you to Saskia and all the collaborators who've been involved in this work, and very much to the funders more broadly who have made it all possible. So thank you.